Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling something called Neuroleptic Malignant Syndrome. So as always, let's kick it off with our practice question to get things started. We have a hospitalized client with schizophrenia who is being treated with haloperidol. He has a sudden onset of high fever, severe generalized muscle stiffness, confusion, and profuse diaphoresis. Which action should the nurse take first? We have A, administer prescribed PRN lorazepam for agitation and reassess in 30 minutes. B, hold the haloperidol, notify the provider, and prepare for emergency treatment. C, apply a cooling blanket and recheck the client's temperature in 1 hour. Or D, document the findings as expected side effects of antipsychotic therapy. Think through your answer and we will come back to it at the end of the episode. But first, to really understand neuroleptic malignant syndrome, or you might hear people abbreviate it NMS, we are going to kind of zoom in on dopamine and what our antipsychotics do. Because if you can't solve from the practice question, it does have something to do with our antipsychotic treatment. So I'm going to start us off here with just dopamine. Dopamine is one of the brain's main messenger chemicals, okay, that neurotransmitter. In very simple terms, it is going to help us regulate movement, mood, motivation, and it's kind of like the brain's filter for what's real and what's not. Now, in schizophrenia and in some other psych disorders too, dopamine signaling is thought to be too high in certain pathways, and that can contribute to both hallucinations and delusions. And that's where enter our antipsychotics. Most of our typical antipsychotics, remember we have typical, atypical. The classic example of the typical antipsychotic is our haloperidol or Haldol. And even many of our atypicals, like risperidone, for example, they work primarily by blocking our dopamine D2 receptors. Think of them as like putting earplugs into the dopamine receptors, so all that extra dopamine can't yell so loudly at the postsynaptic neuron. That's how they help kind of calm psychosis, reduce hallucinations, delusions, etc. But dopamine doesn't live only in the thought and mood parts of the brain. It also runs in the movement pathways, the reward system, and the hypothalamus, which is very important for us today. The hypothalamus, remember, is kind of like the body's thermostat, autonomic control center. And when we suddenly block a lot of dopamine very strongly, with maybe like a high dose, high potency, or rapidly escalated antipsychotics, it can really scramble those systems. So to recap, with schizophrenia, we are thought to have an excess in dopamine. We give an antipsychotic like haloperidol to block those dopamine receptors so we can't get so much of that extra dopamine in there. But dopamine also acts on other parts of our brain, like the hypothalamus. So when we block that, it can really wreak havoc. And this is what happens in NMS, Neuroleptic Malignant Syndrome. You can think of it as the brain having a dopamine meltdown. Several things happen at once. In the hypothalamus, that dopamine blockade breaks the thermostat. So the body is going to lose its ability to regulate temperature appropriately. Heat production is going to go way up because the skeletal muscles are rigid and constantly contracting, kind of like they're stuck in like a cramp or a full-blown Charlie horse. At the same time, heat loss is impaired and the autonomic nervous system is going wild. We get vasoconstriction, tachycardia, and sweating that still can't keep up with all that heat being produced. As a result, biggest takeaway for you guys, hyperthermia. We can get temps over 40 degrees Celsius. That's 104 Fahrenheit. So when we block that dopamine, we get NMS and we have intense, quote, lead pipe rigidity, really stiff muscles that are inflexible, resist passive movement. It is not like shaky, jerky rigidity like you would maybe see in Parkinson's disease. It's more like the body has turned into one stiff, solid board. It is like cranked down. And again, on your test questions, you're probably going to see it called lead pipe rigidity. And let's think about what that does to the body. You've got these constantly contracted skeletal muscles. When muscles are contracting, they're burning through ATP, they're generating heat and stress, and their cell membranes will start to break down eventually. Our muscles are not meant to just be permanently contracted. If those muscle cells break apart, do you remember what happens? They spill all their insides into the bloodstream. We got myoglobin, potassium, creatinine kinase. What's this reminding you of? A complication of NMS is rhabdo. Because we're breaking down those muscle cells, they spill their contents into the bloodstream. And remember what those contents can do. Myoglobin can clog the kidneys and cause an acute kidney injury. Potassium pouring into the blood can cause dangerous arrhythmias. Those CK levels, creatinine kinase levels, are going to skyrocket and cause that dark tea-colored urine, okay? That also has to do with the myoglobin getting concentrated in there. So NMS, tight muscles, lead pipe rigidity can lead to rhabdo. We've got a bad cascade of events going on here. Lastly, remember, the autonomic nervous system is in pure chaos without that dopamine. The sympathetic system is cranked up, giving us tachycardia, high blood pressure, tachypnea, and profuse diuresis. We are hot, sweaty, everything is, fast and irregular, and the parasympathetic system is not balancing it well. So when we think about normal vitals and stuff, everything is going up. We are going too fast because we're blocking that dopamine. Now, before we get into our case study, I do want to take a quick sec to contrast NMS to serotonin syndrome because they can look similar and the NCLEX loves to test that. Serotonin syndrome is when we have too much serotonin. NMS is when we block that dopamine. In serotonin syndrome, we have hyperreflexia, clonus, and more prominent GI symptoms, like, for example, diarrhea. With serotonin syndrome, I am typically thinking about antidepressants being a causative agent. And with NMS, I am typically thinking about antipsychotics because of the neurotransmitter that they affect. With serotonin syndrome, I'm thinking like clonus and hyperreflexia. Versus NMS, I'm thinking about that lead pipe rigidity. And I'm really honed in on that fever from those really tight muscles. Now, we did do a whole episode on serotonin syndrome, so make sure to listen to that to do a little compare and contrast, but hopefully that helps set the record straight and will lead us right into our case study today. So we have got a nurse working on a psychiatric unit, and she admits a 29-year-old man with diagnosed schizophrenia. He had come in through the emergency department after several days of worsening paranoia and agitation. And in that emergency department, he was given multiple doses of IM haloperidol and then started on a scheduled oral dose to more quickly get his symptoms under control. He gets up to this nurse on the floor and he's calmer, but still pretty disorganized. And we're needing to get those medications in check. So initial assessment at the start of the shift here. We've got a temp of 37.8 Celsius. A heart rate in the 90s, blood pressure is mildly elevated, and he's a little stiff, but nothing that is alarming. He's tired, he wants to go to sleep, and this nurse is like, okay, he's finally settling down. I'm going to document my admission assessment. So fast forward, we're going to get our first nurse's note 4 hours into the shift. A tech comes and grabs her and says, hey, something is off with this client. So we go in and do a reassessment. Here is our note. The client is soaked in sweat and won't fully wake up. Face is flushed and there is notable tachypnea with shallow breathing. On attempt to arouse the client, he opens his eyes, but seems really confused, mumbles a few words, and then drifts back off again. Vitals are a temp of 39.8, a heart rate of 128, a BP of 168/96, and respers at 32. On neuro exam, the client has very stiff arms and legs. No clonus is noted, and passive movement is met with uniform, unyielding resistance. Okay, so thinking about that nurse's note, back up here and put the puzzle pieces together. He was very recently started on high-dose haloperidol. He got several IM doses in the emergency department, and then we started him on an oral dose of that to get things more steady. So that means he got at least 3 doses of haloperidol within the past, 6 hours or so. You've only had him for 4 hours. We now see his temperature is climbing. He's hard to wake up. He's diaphoretic. All his vital signs are going up. He's tachycardic, hypertensive, tachypneic, soaked in sweat. And then there's that classic rigidity. His muscles are stiff. When you try to passively move them, you're really not able to. That's that lead pipe rigidity. So what do you need to do if you've got a client who got an antipsychotic and then you're recognizing these symptoms of potentially the emergency of neuroleptic malignant syndrome? You need to stop the offending agent. Do not give any more of that antipsychotic, okay? If he's scheduled for haloperidol, you are going to hold that haloperidol and you're going to make sure no one is giving him anything else that's blocking dopamine. This problem is being caused because we have blocked too much dopamine, okay? So we're not going to do any more of that. Next thing you're going to do is go ahead and notify that provider. Be very clear. I'm worried about NMS. Use language from that nursing note to really give your assessment about why, and the provider will come to the bedside. Your focus is going to be ABCs: airway, breathing, circulation. Raise the head of the bed, apply some oxygen, usually just, a couple liters nasal cannula. Remember, they're very diaphoretic, so remove those extra blankets and clothing. You might even do a cooling blanket or cool packs in the armpits and groin to help get that temperature down. You're also likely going to start a large bore IV and begin infusing isotonic fluids for perfusion to protect the kidneys, since we know we've got that lead pipe rigidity, those skeletal muscles contracting, and that can lead to rhabdo. We want to get way ahead of that. Now, the provider is likely going to get some labs to work this up pretty quickly: a CBC, CMP, CK, coags, ABGs, and definitely a urinalysis to check for any myoglobin. We're also going to get them on continuous telemetry. We want to watch their rhythm because we know they're at risk for hyperkalemia if we go down that rhabdo pathways. And this is a client that is probably going to be transferred to the ICU because they need very close monitoring, okay? There's nothing we can magically do to reverse that dopamine blockade. So we focused on those ABCs, supportive care. We try to get ahead of the rhabdo with fluids, cool them down, and really support their body as they clear that medication, and we balance that dopamine again. Now, 2 medications that can be given in the ICU is IV dantrolene. This is a direct-acting skeletal muscle relaxant that's going to basically relax those skeletal muscles. That's going to reduce the rigidity, which helps reduce the heat production and get that fever down and prevent the development of rhabdo. So IV dantrolene, relax those muscles. And then we also may give benzodiazepines like lorazepam, for example, to, again, help with that muscle tone. We're going to try to relax things. Again, it's not going to reverse the dopamine blockade, but it is going to be good supportive care as the body clears that medication. The ICU nurse over the next 2 days is going to monitor that temp and those vital signs almost constantly. Really close eye on that urine output, adjust fluids to protect those kidneys, track those labs. We're going to stay on that continuous telemetry to look out for arrhythmias. And as that medication is cleared, all that extra haloperidol he got kind of gets out of his system. Dopamine's going to regulate. We're going to become less rigid. The fever's going to drop. All these things are going to start to improve. And usually this is a relatively long ICU stay, at least 1 to 2 weeks, depending on how severe the NMS was and how much of that dopamine he got. So he's probably going to be off that antipsychotic for a little while before he gets transferred back over to the psych unit and the specialists start trying to kind of work out the medication regimen that can balance this. It's one big balancing act because this is a client with schizophrenia that we, need to treat those positive symptoms of hallucinations and delusions, but we don't want to overdo it, block too much of that dopamine, and cause NMS. So that being said, it brings us right back to our practice question. Let's see now if you can get to the right answer and understand why. A hospitalized client with schizophrenia is being treated with haloperidol, and they have a sudden onset of high fever, severe generalized muscle stiffness, confusion, and profuse diaphoresis. Which action should the nurse take first? We have A, administer prescribed PRN lorazepam for agitation and reassess in 30 minutes. B, hold the haloperidol, notify the provider immediately, and prepare for emergency treatment. C, apply a cooling blanket and recheck the client's temperature in 1 hour. Or D, document the findings as expected side effects of antipsychotic therapy. Think it through for a minute. I know you guys have got the right answer, so shout it out, jot it down. What is it? It is B. We are holding that haloperidol and notifying the provider. This is the classic presentation of neuroleptic malignant syndrome. We know that we recently gave an antipsychotic, haloperidol. We see a high fever, that rigidity, the high vital signs, tachycardia, hypertension, they're diaphoretic. So we know we have an emergency. That means we got to stop the causative agent. No more of that haloperidol and call the provider. Option A, giving lorazepam and reassessing later, delays action. It is not wrong to give benzodiazepines like lorazepam, but if you're just like, oh, this is agitation or this is anxiety, you are missing the point. This is a rapidly evolving emergency. You cannot watch and wait. That's also why D, document the findings, is incorrect. This is not an expected finding. We need to escalate. And same with C. Again, it's not wrong to apply a cooling blanket. We want to get that temp down, but recheck in an hour? No, we are escalating. This is an emergency. That is your big takeaway, all right? If you give that antipsychotic and you suddenly see high fever, rigidity, autonomic instability like tachycardia, tachypnea, hypertension, and diaphoresis, you need to think neuroleptic malignant syndrome. Your priority is to discontinue that antipsychotic and call the provider. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.